My name is Dana Goldman. I'm the director of the Leonard D. Schaeffer Center for Health Policy and Economics here at the University of Southern California. I'm also the interim dean of our policy school. And it's my pleasure to welcome you to this four-part webinar series on precision medicine. If you think back to the way we've been practicing medicine for several centuries, it's really been learning by doing. That is, doctors will examine patients, get a few biometric measures, if you will, and try out different treatments to see what would happen. In economics, we call that an experience good. And what the revolution that we've seen in precision medicine is one that's moved the world from experience goods into what we will call an informational transformation, if you will, so that we actually will know how valuable a medicine is, not after someone's tried it, but beforehand. And we do that through diagnostic testing and the like. And what that does in terms of, it changes the value story that we hear around treatment, because we can better tailor the treatment, medical treatment to patients. It also means we get more value and less failures. That has implications for pricing. It also has implications for how we think about diagnostics. For example, if only 20% of cancer patients respond to a particular treatment, and I can develop a diagnostic that would identify those 20%, on the one hand, I've cut the size of the number of people to treat by 80%, and that reduces revenue. On the other hand, for those 20%, it can really change their lives, and that generates a lot of value. And so this raises both opportunities and challenges that we are going to explore in this four-part series. And we're going to view this through the lens of all the stakeholders in the healthcare system. So today we'll be talking about how we can leverage precision medicine to meet patient needs. And then later on in this series, we'll talk about what it means for how we measure effectiveness and value. And some of that story I already intimated at. We'll also look at how it's going to affect clinical practice more broadly. And then finally, we'll address some of the challenges for payment and reimbursement. And as you know, those are quite substantial. So with that, I'd like to turn over today's discussion to a very esteemed panel. And I'd like to introduce our moderator for today's webinar, Dr. Arlene Bierman. She is the director of AHRQ's Center for Evidence and Practice Improvement. She's a general internist, a geriatrician, and health services researcher whose work is focused on improving access, quality, and outcomes of healthcare for older adults with chronic illness and in disadvantaged populations. And she's published widely in these areas. She serves on prestigious advisory committees for geriatric measurement, for NCQA, and for PCORI's methodology committee. She was a tenured professor where she was the inaugural holder of the Ontario Women's Health Council Chair in Women's Health at the University of Toronto. And she received her MD degree from the University of North Carolina School of Medicine in Chapel Hill, where she was a Moorhead Fellow. Arlene, welcome, and I'll turn it over to you.
Thank you, Dana. Today's program will include brief remarks from our three speakers, followed by a moderated discussion and Q&A. Audience members can submit questions at any time using the Q&A feature. Please let me start by introducing our first speaker. Winora Johnson is a three-time cancer survivor. She's a research and patient advocate and Navy veteran, and she began working closely with the organization Fight Colorectal Cancer as a research advocate following her diagnosis of stage 3B colon cancer in 2011. As a Lynch syndrome patient, Winora also advocates for genetic testing and awareness. She serves on various panels and review boards to provide extensive feedback on her role as a patient and a research advocate. Welcome, Winora.
Thank you, Dr. Bierman, for that great introduction. and also for the opportunity as a patient advocate to provide my viewpoints and what we see from the patient's viewpoint. And what I would like to start off and to begin with is that many of us patients really don't even understand and know what precision medicine is, or just the definition of it. So that means that we need to gain an integral knowledge and understanding of what exactly it is. And it's viewed as an emerging approach for disease treatment and prevention that takes into account the individual's variability in genes, environment, lifestyle for each person. So for me, as a 3-time cancer survivor, finding out through genetic testing that I was a Lynch syndrome patient with an MSH2 mutation, immunotherapy would be a better treatment option for me. And this is what precision medicine does for the patient. It gives you another opportunity or outlook at treatment options. And for me, because I am a Lynch syndrome patient, it's going to be even more important in the future, these opportunities for precision medicine, because I'll have additional cancers in my future. The next thing is just plain old lack of awareness. Many of us patients just don't even know about it. So this is where it can be really important on behalf of physicians to shift and share with their patients and empower them to become knowledgeable about precision medicine. So share with them what exactly it is and their position and what they're doing in regards to precision medicine. So some points that I wanted to bring out is that it's really not discussed a lot with patients. So discuss it with us. We're afraid maybe sometimes to even speak up and ask questions. So building that level of trust and transparency first patients, it really helps us to understand it's nothing to be afraid of. And that realizing that precision medicine, it's important because it's not a one size fit all concept. So chemotherapy shouldn't be the only option every time a person is diagnosed with cancer. Now, one of the more important things about empowering patients are these 3 circles that I've got described here. And one is giving us access to medical information. I know for me, it's been a great opportunity just to really jog and look through my journey as a cancer patient, because I'm connected to my chart and I can see what's taking place between all of my healthcare team. And then providing us with educational resources will really help us understand what precision medicine is all about. So if I go and visit my oncologist, and maybe if he has a pamphlet or something to provide me that talks about precision medicine and what it could do for me, will help me a lot in understanding that. And then just sharing information with patients. What happens afterwards. I think the rest of the series will also talk about costs associated with precision medicine and those things. Those are things that provide transparency and helping the patient really understand the precision medicine itself. I'd like to share with you what was interesting is that precision medicine was so important that even in President Obama's administration, they had set aside an important initiative for it. In fact, if I could read his quote here, it states that doctors have always recognized that every patient is unique, and doctors have always tried to tailor their treatments as best as they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to your genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking your temperature? So it just goes to show that even far back as 2015, the idea of precision medicine was viewed as vital and important for patients to have options. And then lastly, I'd like to share one of my favorite quotes that I've been using as a patient advocate, and that in some way we're all a little broken, but that quote states that broken crayons still color. So we still have value. We're still important in this initiative. And I think precision medicine can do exactly that for us as patients. Thank you.
Thank you, Winora. Now I would like to welcome our next speaker, Pavan Bhargava, and he's an assistant professor of neurology at the Johns Hopkins University School of Medicine and a member of the Johns Hopkins Multiple Sclerosis Precision Medicine Center for Excellence. His research interests include utilizing a variety of techniques to identify new diagnostic and prognostic biomarkers and to better understand the pathogenesis of multiple sclerosis. He utilizes approaches that will allow for more individualized interventions and precise monitoring of disease progression and treatment response. Welcome, Pavan.
Thank you, Dr. Bierman. I'd like to thank the organizers for giving me this opportunity to speak at this webinar. I'm a neurologist and I treat patients with neurological disease and specifically patients with this chronic neurological disease called multiple sclerosis, which is a autoimmune disease that affects the brain and spinal cord. And I'm going to talk a little bit about how we are trying to bring precision medicine into MS treatment and diagnosis to better meet patients' needs. So I think Winora Johnson gave us a really nice overview of what precision medicine means. And unlike oncology, where precision medicine really has made great strides, neurological disease is still lagging far behind. And so I'll talk a little bit about how we still need precision medicine to make more inroads into this field. So in multiple sclerosis specifically, there is need for more precision medicine, both in the diagnosis of the disease, prognostication of the disease, as well as tailoring treatment. And just to give you some examples of, studies have shown that about 20% of people who carry a diagnosis of MS are actually misdiagnosed. And these patients then end up exposed to unnecessary interventions, which have significant adverse effects. So improving precision in the diagnosis of MS could help prevent these people from being harmed. Besides this, we know that multiple sclerosis is a very heterogeneous disease. Some people will have really mild disease and not require, not accrue disability over the course of their disease, while others may be disabled with this disease in a year or two. And that is something we are still struggling to predict, is what a person's prognosis will be over time. And lastly, we have over 17 different disease-modifying therapies that can decrease disease activity in people with MS, but we still have no way of figuring out which person will respond to which of these 17 different treatments, resulting in basically a trial and error approach. So I'm going to just briefly give a couple of examples of how current research is trying to help, address each of these areas. And then, if there are questions, we can talk about these in a little bit more detail. So just as an example, there's ongoing research that is trying to reduce MS misdiagnosis. And one of these is a new MRI technique. So this is a kind of scan that can be done, which looks for a specific finding, which has been known for hundreds of years that there are lesions of multiple sclerosis center around tiny blood vessels in the brain. But until recently, we couldn't actually see this on an MRI, but now we can. And seeing this on the MRI can help. If you see this in a large number of the spots or lesions that we see on the brain scan, we can actually differentiate people with MS from other diseases, and this can help reduce misdiagnosis. And there are currently large studies ongoing to confirm that this can indeed be used in clinical practice. Similarly, like I was telling you, we have lots of different treatments that we can employ for patients. And right now, trying to determine which treatment a patient should go on is essentially an exercise that requires us to consider many different factors, including what preferences a patient has, what their risk tolerance is for adverse effects, what we consider the severity of their disease to be based on the information we have, but then also system-related factors like, what the insurance will pay for. But again, being able to employ precision medicine to figure out whether a certain subset of patients will respond to a particular treatment would really help us narrow down, the treatments that a person might be eligible for, and really help with these decisions, which currently are really challenging. So, I'm just going to give you briefly an example of of recent work that was done, where looking at scans that had been acquired in thousands of patients over multiple different clinical trials, researchers in the UK identified 3 different patterns in which their disease was progressing, whether it was progressing due to accumulation of the spots that I showed you, whether it was due to changes in the deep parts of the brain, which are called the white matter, or in the surface of the brain, which is called the cortex. And what they found was if you divided people into these 3 groups based on their brain scans, the ones where the disease was being led by accumulation of new spots, they responded the best to treatment. And those in whom the disease was basically being driven by involvement of the surface of their brain tended not to respond to conventional treatments at all. So this really helped, this kind of a classification could then really help us in identifying those who would benefit most from treatment and in choosing a treatment for our patients. And then lastly, I'll give you an example of another test that is being developed. And this is a blood test that looks for a protein that leaks from nerve fibers when they're damaged. And what we've currently, when we're trying to figure out whether treatment works for a person, we have to wait and watch them to see whether the treatment prevents more symptoms from occurring, or we have to do MRI scans, which are expensive and time consuming. We have to repeat those every 6 months or every year. But this blood test that, you can draw just like routine blood work can actually tell us whether someone might be having ongoing disease activity. And, in these pictures on the right, you can see that if you look at people in the blue who are on the top graph who remain stable during this clinical trial, their levels of this protein were really low and they didn't vary over time. While if you look lower down at the lower graph, you can see that people who had evidence of ongoing disease activity, they had higher levels and their levels tended to bounce around. And so, this is just an example of a test which is still at a stage in a research setting that might help us identify people who are not responding to a treatment sooner and transition them off to another treatment which may potentially shut down the disease rather than having to wait and wait for conventional measures. So I'm going to stop there, and just because I wanted to give people an idea of what is ongoing and how we might be able to use precision medicine in chronic neurological disease.
Thank you, Pavan. Now I would like to welcome our next speaker, Rhoda O. She's a professor of anatomy and neurobiology, neurology, and epidemiology at the Boston University Schools of Medicine and Public Health. She's a senior fellow at the Institute for Health Systems Innovation and Policy at the Questrom School of Business. She also serves as director of neuropsychology at the Framingham Heart Study, where she has been using technologies to develop digital cognitive biomarkers as surrogate indices of fluid and imaging biomarkers. She is also focused on building multi-sector ecosystems to enable solutions that move the primary focus of health technologies from precision medicine to a broader emphasis on precision brain health. So welcome, Rhoda.
Thank you so much for having me. And I wanted to sort of shift the conversation a little bit toward precision brain health. And why do I want to do that? Because it's actually the case that when we think about brain health, many of the diseases are insidious in onset. For instance, I'm very interested in cognitive aging and dementia with a particular focus on Alzheimer's disease. And so I really think that as we've come to understand these insidious onset diseases, we start to realize that they're really life course diseases. So it turns out that Alzheimer's disease isn't something that just happens to you when you're getting older. It certainly emerges at that time in terms of clinical symptoms, but it's actually been a process that's been going on for a very long time. And so I think about precision brain health as something where you really want to optimize people's brain capabilities wherever they are on that continuum, and that would be from healthy as well as to disease. So along those lines, in thinking about how do we build this precision health initiative, we've been really thinking about how technology can be brought in to help us. So if we think about how we do things now, this is really pretty much how we think about studying brain health in the traditional way, which is to have people come into the clinic, give them all sorts of, different assessments. But it also turns out that that's a very high burden option for studying a disease. So it turns out that right now in the world of Alzheimer's disease, 90% of the data is actually only on 10% of the population. So we're painfully, woefully underrepresented in our methods currently. So if we think about what technology then can enable, is that we can start to bring in different kinds of devices that will also take us from this sort of sporadic, occasional data collection. And again, I mentioned that things are insidious in onset, so you really want to be able to collect on a more frequent and more granular basis to pick up much more subtle changes much earlier in the disease process. And these, at the same time, in terms of participant burden, can sort of be easier for participants to do on an ongoing basis, particularly, as we move into remote technologies that can be used in people's homes. But I think that the really holy grail of where we're trying to get to, if we really want to achieve this concept of precision brain health, is to really move from what we call active engagement technology, which is what most health technologies are today, into passive engagement technologies, ones that collect data on a continuous basis without really requiring a lot of effort or burden on the participant. And I think once we get to that point, we'll be well on our way to establishing this precision brain health concept and really making it a reality. Now, within this context of, and particularly around digital, there's this, recently there's been sort of this huge emergence and interest in the concept of digital biomarkers. I actually started using the term quite a few years ago now. And back then people would reprimand me actually when I tried to use it, saying that digital and biomarkers are not two words that belong together. But today, actually, digital biomarkers seem to be all the rage, particularly in the technology front. And I really want to address and spend some time talking about, well, what does that mean? What is a digital biomarker? And are we really conceptualizing in the way that we need to? So we think about, how do we collect that data? We're going to use multiple sensors, and it needs to be multi-sensor from different kinds of devices, applications, in-home, on your wrist, through your phone, and through smartphone devices, et cetera. And then we need to aggregate all that data together. And this is really where we bring in our data science AI colleagues to help us analyze this multidimensional data much more effectively than our traditional biostatistics or epidemiologic methods allow us. But here's the thing, and I think this is really important for people to think about, what's going to be that output? Because when we tend to think about the word biomarkers, we tend to think about something that's a consistent signal. You measure something, you measure whether it's, blood or cell or, imaging, et cetera, and you expect to get some sort of consistent signal that suggests that your assessment of interest is being measured. But in fact, when it comes to this concept of digital biomarker, the output is actually going to be very dynamic. And I put this word fluidic in front of it because I wanted to give people a sense that it's going to be flowing and changing all the time. So I like to remind people, particularly, let's say in the instance of Alzheimer's disease, when you have early indications of memory impairment, for instance, you might forget to turn off the stove. You might forget where you're going. You might get lost in a familiar place, et cetera. But it turns out you don't always turn off the stove. You don't always get lost. You don't always misplace things. The reality is, on a day-to-day basis, what you do continues to fluctuate. But over time, you pull all that different information together in order to say there's a memory impairment. And that's really the idea of how we need to rethink what we mean by digital biomarker. It's not going to be a single signal. It's going to be this ongoing flow of information that's always changing, but collectively represent that some significant change is happening. So to that end, once we're able to really define effectively what a digital biomarker really is, then that really sets us up for how we move this into clinical care. And so, we have these ongoing multi-sensor inputs coming in. They're going to be analyzed in some cases with really automated capabilities, fed back to the person in some actionable way. And then over time, if there's significant symptoms, potentially fed back to family, clinical care. And then you're going to get this sort of feedback loop on an automatic, on a routine basis, on a continuous basis. And I think that that's really where we can take this concept of digital biomarkers and really move it and unleash the power of it to affect care. So I'm going to end there, and thank you for allowing me to spend a few minutes giving you some of my thoughts.
What great presentations. Thank you to all of our speakers, Winora, Pavan, and Rhoda. I have a question. Actually, I want to start with a question for Winora. As a cancer survivor and somebody who has Lynch syndrome, what have you learned and what advice would you give to other patients?
Thank you for that question. For me, it's that you definitely want to talk to your doctors. Talk to your healthcare team and let them know that, have a dialogue, have questions for them and ask them about precision medicine. Or if you're a fairly, a patient who's fairly knowledgeable about the latest information about healthcare and things of that nature, then share with them your thoughts. So for me, as a Lynch syndrome patient, I'm constantly having talks with my doctor because I know that there are more possible cancers in my future, and I want to be prepared, as well as my healthcare team.
Thank you. Actually, I have a question for Rhoda and Pavan to follow up on this. Winora is an activated patient, knows exactly what information she needs and what she's looking for it. But my guess is that a lot of clinicians are not aware of this. And do you have suggestions for how to make sure that clinicians who are seeing patients who could benefit from precision medicine actually have easy access to what's available?
Pavan, go ahead.
Okay, so I think this obviously it's really the communication is really important, right, between clinicians and patients, because that's how we can actually move this precision medicine into the clinic and really apply it to improve patient outcomes. I think I think this varies across, like diseases. In some cases, like a lot of the precision medicine efforts, I think, are still at a research stage, right? And may not be, haven't yet been put into clinical practice. So I think, doing the right studies to show that, things that are, or new tests or new biomarkers are actually useful, right, in identifying subsets of patients or in tailoring care to patients, that would be your first step, and then getting buy-in from clinicians as well as patients through better education and dissemination of those results. I think that would be the next step to actually getting precision medicine to into the clinic and to helping patients.
Yeah, what I would say is I think that the number one barrier right now for us to getting to accurate precision medicine, or in my case, precision brain health, is we don't have the right data. So we're very research driven, obviously, in how we do this. And I did mention that, for instance, in the world of Alzheimer's disease, and this is not limited to Alzheimer's disease, that 90% of the data is on 10% of the world population. In the US, we have to be particularly concerned about this because we have a very racially, ethnically diverse population, and we're not studying them. And the reality is that precision, which is very much driven by analytics are very dependent on having the right data. So right now, we don't have the right data, and we're not going to get there until we do. So we need to take a much more, we need to, I guess, cast a much broader net. We need to figure out how do we actually bring in the kind of data that represents the entire population, not a part of the population. And then we will start to develop sort of the right tools for the right person at the right time that will be effective for physicians, because they also will see a very diverse range of different patients. And they need to have the tools that reflect, because every patient, every clinician wants to serve that patient in front of them. But that patient in front of them brings in a unique set of factors and variables. And if we don't put the right data together, we'll never put the right tools in their hands in order for them to effectively treat the entire range of patients that they're likely to encounter.
I'm going to follow up with Winora. Given that, what is the best way, what is the role for patients and patient advocates to help with educating about the potential of precision medicine?
Well, for one, as advocates, we have a voice. We have an opportunity to talk about our treatment options, what's affected us in the past, and what's going forward in the future. Opportunities like what I have now to talk on a panel with the USC and give my viewpoint as a patient are so critical and important, because it allows patients to identify with someone, and that way they can feel that empowerment that I talked about, and maybe talking with their healthcare team and provider.
Thank you. And actually, I'm going to direct the next question to Pavan and Rhoda again about what are the specific roles of artificial intelligence, AI, in configuring more precision in the diagnosis, prognosis, and treatment of multiple sclerosis and Alzheimer's disease.
So Pavan, you want to go ahead again?
Sure. So, I mean, I think, these are, I mean, there's definitely a big role for this, given, that we are, a lot of what we're doing in terms of precision medicine is gathering really large amounts of data, and, the both artificial intelligence and machine learning kind of, approaches are going to be really important in helping us, understand that data and identify, signals that will help us subset patients and help tailor, therapies to those patients. So for, like I alluded to in my presentation, so that was one of the approaches that was used to actually analyze data from, like almost 10,000 MRI scans of MS patients from various clinical trials to subset them into these bins, which then could help predict whether they would respond to treatment or not. And similarly, we currently are working on, something similar to what Rhoda was talking about. So we have patients we're looking at the use of wearables in our MS patients, and to track their disease progression. And what we realized was that, we have people wearing these wearables, and they wear them for 2 weeks at a time, and then they give it back to us. And then you get tons of data, not just about, say, how many steps they took, but, when they took them and how that changed over the course of the day. And this is data that is hard to analyze with, just routine or traditional statistical approaches. And so, some of our colleagues who, use machine learning and artificial intelligence were then able to figure out that, it wasn't how many steps a person took or how much activity they were indulging in a day, but actually people with MS had a greater variability in how much activity they undertook in a day. And the more disabled you were, the greater that variability. And that's not something that, we would have figured out unless we were using these kinds of approaches. So I do think that as we start to collect more and more data to help with this, with our precision medicine efforts, that this is going to be really important.
So I would just add to that a few things. First of all, AI is a very much an emerging field. So I think that there's sort of what we think AI can do today, but I think that we need to prepare to think about what AI can do tomorrow that we can't even figure out for right now. But I think for today, what's really important is, and I did mention this earlier, we're talking about, for the most part, insidious onset diseases. And so that means, in particular in the case of Alzheimer's disease, it's not like when you're diagnosed, you were normal the day before, the week before, the year before, 5 years before, or even probably 10 years before. We now think that the preclinical symptoms of Alzheimer's disease may emerge as 2 decades prior to meeting the clinical threshold for diagnosis. So what I think that between what I call, technology, hardware, software, and analytics, I think there's an opportunity in which we can use these different technologies in combination in order to monitor on an ongoing basis, even when people are presumably asymptomatic, because asymptomatic is based on our current detection methods today. And so if you're now sort of monitoring people and their ranges of different behaviors through the multi-sensors that I mentioned, what you can start to do across, a lot of variability is you can start seeing when the first negative trajectory of change starts to emerge. And this is still well within normal, by the way. So now suddenly you have an opportunity potentially to intervene much earlier on. And if you intervene much more earlier on, then it's likely that your interventions are going to be much more effective in terms of treating and arresting, and potentially, given how far back you may do this from a prognostic state position, may even then start to prevent the disease by changing that trajectory altogether. So I think that is the promise of AI today. But I always warn people that, we have to be very careful. AI is now sort of used as a catch-all term, and it means many things. And in of itself, it will still need, guidance by physicians, definitely. It needs the right data, which I mentioned to you, earlier. And then it's got a life that we don't even know yet in terms of the possibilities. And so we just want to be prepared for the opportunities today, but also the opportunities we can't even see yet.
Dr. Bierman, if I could quickly jump into that too.
Sure.
When it comes to AI, and this is where transparency is important to patients, that when you're collecting this information and you have this data available, sharing it with your patient and saying, hey, we've come across X, Y, and Z information, and we just want to share it with you, again, gives us a sense of trust, along with you providing that transparency. So great, you're going to use AI, but then share it with your patients too.
So could I jump in? Because I would actually turn that around and say that the data should go to the patient and the patient be sharing with the physician, and they should be working together. So I actually think that if we move in this direction, that's why I like to talk about brain health instead of disease, right? Because when we think about medicine, we always think about a patient and a clinician. When I think about health, I think about, well, no, I'm putting this in the person's hand, of which along the way they may become a patient. And I think that it should be an interactive relationship. So it's as much the person being able to provide informed information, because you know yourself better than anybody. So if you have the information and you have the tools to gather that information and you can bring that information to your physician, then I think you have a much more effective model than just the patient sitting back and waiting for the doctor just to tell them, right?
I'm going to ask a follow-up question to all of you related to that. Building on a couple of your comments, is sort of the role of shared decision-making. It sounds like, these decisions are complex and really, require weighing a lot of different elements, a lot of different factors. So how do you incorporate shared decision-making to really make the best choices? You talk about precision health, I talk about precision care, which is all related. So how do we do this to make sure the patient gets the treatment that's right for them?
So for me personally, that's why I like to think about you're a person first before you're a patient. So it's kind of like, we don't call you an Alzheimer's disease patient, we call you a person with Alzheimer's disease. So I feel like we need to change our language a little bit so that we can change our perception a little bit here. And so I think that it's about, I think that Honora talked about empowering, right? Well, I think we can empower people to take that and engage with their physicians on an ongoing basis. And that's where I think you'll get the kind of precision care that you're referring to, that because it is a care treatment won't be right. It could be the same stage, it could be the same disease, it could be same, but that particular treatment plan won't work for that individual because of lots of other factors. And so I think that it's very easy to sit back in a theoretical way and be prescriptive that this is the right solution, right? But I think that, in fact, until you do this in an interactive way, so you're taking into account the individual and their circumstances and coming up with a care plan that actually works within the environment that they have to live within.
I love that concept. But, for some of us, it's hard. I'm a patient advocate. I'm a passionate patient advocate, and it probably comes through. But what about for those individuals who can't speak up? They're afraid to speak up. I know for families of color, or for Black people, we don't even talk about our past history of illnesses, just so that the next generation can know what they're facing. So sometimes it's really hard as a patient to speak up and say those things because you've been taught just to be quiet.
I do think that that's though where the clinician could come in, right? So it's not just, again, I kind of, I think we need to get away from the patriarchal system. And I think that but I do think that maybe if you have a good relationship with your clinician and also with your community in general, there are other health advocates out there. I think that maybe you can figure out ways in which to build, to start to bridge those. But I think it's also that there is a certain amount of culture shift, a mindset shift that needs to happen. And so it won't happen overnight, it's over time. And then over time, people will see success, as you say, transparency, right? I mean, part of the fear is because they don't have the transparency. But if you have the transparency and you're seeing the benefit, then that may then empower you to move in directions that previously you felt uncomfortable.
Yeah, so I agree with both, with what Rhoda and Winora just said. And, I think, I mean, I do this on a day, like almost daily basis where, we have this challenge of trying to, match patients with treatments. But sometimes, and like I said, we take lots of different factors into account, but ultimately it's a shared decision that needs to be made. And I mean, it's a decision ultimately that needs to be made by the patient, right? I can't dictate, okay, take this medication because, there may be a reason why the patient just doesn't, and then the patient might just not do it, right? So if I choose to give a patient a medication that is an injection, and this person is dead scared of needles, right? And we didn't have a discussion about that, then even if that medicine is the right medicine for that person, it won't be effective because that person's not going to take it. So I think, taking, like Rhoda said, taking all of the factors into account is really important. And I think that's part of, precision medicine and precision care, is providing patients with sufficient information that we have to make the decision that's best for them, right? And I think precision medicine is just about getting to or being able to have even more information to be able to tailor that care, even better. And I think that's where hopefully we're headed, right? And we're going to get to the point where some of that, wasted time or wasted effort might be eliminated by this process.
Yeah, I have a question, from one of the participants that was really interesting. It says, how do you help or make the physician accountable for learning about the latest discoveries and developments in their special fields and incorporate them in clinical care from research to bedside? And I think, this is particularly relevant for ARC because we want to accelerate, the old, like 17 years from discovery into practice. What do we do to really make sure first of all, we know what's effective and we understand the benefits and harms. And once we do, how do we communicate that and make sure that, they're widely known and used?
Yeah, I mean, I think there are really two aspects to this, right? One is obviously doing the right research, right? And so obviously things need to be, studied properly to show that they're actually, measuring the right thing, are actually helping improve care. And that's one part of it. But the second part is actually then bringing it to the patient, and some of it, part of the problem is regulatory, right? So for example, I showed you this central vein sign that we're studying to improve diagnosis in MS, but that can't be used until that particular sequence is approved, right, by the FDA. It's put into all the scanners that are out there, clinical scanners, and then you need radiologists to get on board to actually read those scans. And, unless all of those things happen, this is not going to go from research to clinical practice, even though it might potentially benefit patients and it's useful. So, I mean, I think, getting all the people who are, stakeholders on board is equally important as, the research that's happening, and that's what's going to really help get things from research to the patients. And it's the same thing with, the other biomarkers that are being developed. None of these are going to get to practice unless they're approved by the appropriate, like, regulatory bodies. And, for that matter, like, if the FDA is not going to accept a particular biomarker as a surrogate to help approve treatments, then that you won't know what the effect of a particular treatment is on that biomarker. So I think it's really important for all the stakeholders to be aware of these issues, and that regulatory piece needs to move forward along with the research.
So I would agree with that. I mean, certainly in the realm of digital biomarkers, the regulatory pathway is still yet to be determined. But assuming that you do get sort of through, FDA at some point, and I'm sure that they will come around to figuring this out, I think there's actually two pathways in which you get this into the clinical care. So one, people like Winora. They are going to educate themselves. They're going to bring their information and they're going to bring it to their physician. And their physician is going to need to answer to them. So that's plainly one way. Number two is you're going to incentivize it. I'm sorry, but how do you get people's behaviors to change? You incentivize it. And how do you incentivize it? In the healthcare field, it tends to be through billing and insurance. So I think that once you link that, and presumably if you have people like Winora bringing their information, we're collecting it much more accurately, come in very informed, you're actually taking some of the burden off of the physician in terms of, figuring out, collecting some of this information. And maybe instead you incentivize that time so that they're spending time understanding what these novel, different patterns really mean, and then again, working with their patients. So I think it always comes down to what is the billing going to, reinforce at the end of the day.
Thanks. I see we're just about out of time. This has been a great discussion. Is there any last comments that any of you want to add?
I have a quick one. And I just want to say to both the doctors, all three of you doctors here on the panel, that this has been very enlightening for me as a patient advocate, because we get so deeply ingrained in our patient advocacy that sometimes we forget that those outside of that, who are doctors and physicians and researchers, they don't want to see any of us die or have to suffer either. And so what I'm saying is I appreciate your transparency. You're giving me the knowledge to be empowered to even do more and continue with my work. So thank you all. And thank you, Schaeffer, for allowing this conversation to happen.
I just want to thank all of you. That was a fascinating discussion, and I like the precision care label. And the discussion touched on how this is not just about traditional diagnostics, it's about all sorts of biomarkers and imaging and digital technology. And at the center of it, the patient and the physician, and the ability of them to make choices that are tailored to everyone's needs. So Dr. Bierman, thank you for moderating this session. I want to thank AHRQ for supporting this webinar series. And we hope that a lot of our audience members will be able to join us for the next 3 installments. But again, thank you to all of you for your participation.